next speakers are two. We'll get double dose here for this, is improved care and patient satisfaction by understanding patient populations. Have one of our own who has been with us in years past in some of our meetings. Deborah Grimes is the Chief Diversity and Inclusion Officer at UAB, and Mary Coleman Dobbins is the Patient Experience and Engagement Analyst at UAB. They're going to be sharing today their work in exploring the differences in patient populations and developing processes to meet the varying needs to improve care and the quality measure scores that we're all chasing. Deborah served in a number of leadership roles at UAB, including quality and compliance. She has a Bachelor of Science in Nursing from UAB and a law degree from Birmingham School of Law. She also has her Master's in Quality and Patient Safety from UAB. Mary Coleman Dobbins, for 10 years, she's worked in a number of areas, including population health, pharmaceuticals, human resources, and more. She holds a Master's of Public Health from UAB and is also a graduate of the UAB Healthcare Quality and Safety Certificate Program. We're delighted to have Deborah and Mary with us today and improve care and patient satisfaction by understanding patient population. Come up, please. I'll turn this one off. Oh, you need this one.
Good afternoon. Can you hear me? You hear me pretty good? Okay? Okay, great. I am delighted, first of all, that there are people still left in the room. That's always good when you're the last speaker. And I'm more excited to share with you some of the work that we're doing at UAB. My main purpose for doing this is twofold. Anytime Aloha asks you to do something, you want to participate, so that's a great thing. And it also gets me back to the roots and the passion of quality and safety. So I'm really, really excited to be here, and thank you so much for having us. When I was asked to take on this role, I was probably like some of you in the audience. Diversity, equity, and inclusion, I wanted to learn more about it. I did my research, and the more research I did, I found that it was very much in line with our mission and core values. And for those of us who have done the work like I have over 20 years working in quality and safety, you know that we're not a revenue producing body of the organization, right? So when you don't produce revenue, when you're in one of those departments, it's important for you to understand, how do I relate back to the mission? When I started to reflect on our mission, it's really, the big mission is to improve the health and well-being of society, particularly all of the people who live in Alabama. And I'm sure many of you, your mission is very similar to that. So the work that I'm going to talk about very much is in line with this mission. And when we first started down this journey, it was important for us to really talk about terminology. Because sometimes when you talk about diversity, equity, and inclusion, a lot of people think you're only talking about, at a minimum, race and gender. And in our patient population, it's so much more than that. So we spent a little bit of time kind of talking about, when we say those words, what do we mean? And so we put together a group of words, and I won't read all of it, but inclusion really for us is just the act of creating that environment in which every individual feels welcome, feels respected. And we can just stop right there, because as an employee of an organization, or as a patient or a family member, who would argue with that? We all want to be respected. We all want to be welcome. Diversity really just refers to a variety of personal experiences, values, It also includes race and gender and age and religion and all of the things that we talk about, but it's so much broader than that. It's really all about who are you, the person, because our patients and our families don't stop being who they are when we strip them down and say, give me all your clothes and your valuables and put on the hospital gown. I'm still from Anniston, Alabama. No matter where I go, I have that small town version inside of me. And I wouldn't want anybody to stop and tell me I have to act as if I'm from New York. Nothing wrong with New York, for my friends, I have a lot of friends. But I do value the fact that I have a unique experience because I grew up in a small town. And those of you who grew up in a small town know what I'm talking about. So we bring that to the table. I bring that to the table when I am a patient. I bring that to the table when I am employed by UAB. I don't stop that. And so that's what that's talking about. It's just recognizing those unique experiences. And then equity, clearly, is just we want to guarantee that everybody's treated fairly. That's what that's all about. So once we sort of define and we all got on the same page, basically what it's not, and defining for our organization what it is, it's very much in line with our mission and values as well. So I'll just be very brief in how I would like for you to start thinking about diversity. The first thing is every patient, every employee that you encounter starts out this way. We all have a unique personality. And then from that personality, we sort of enter into some internal dimensions of diversity. And when we say internal, we're really talking about things like race and age and gender. But then there are also within all of us those external dimensions of who we are, our religion, our own work experience, whether we're an Alabama fan or an Auburn fan. I have to add to this. I have to say Blazers too, right? So because we're unique in Alabama, we have we have choices when it comes to the football team we want, and that does matter. Those types of things. Whether you went to school in the South or whether you went to school in the North, or all of those things are external dimensions of who you are. And then there are also organizational dimensions. We have to think about our role as a quality profession is very much different from a staff role, or if you're the CEO, where you sit in the organization is a dimension. It brings something. It's a unique experience based off of who you are. So when we talk about diversity, you see it's much broader than what we think about. Same thing with patients and families. They all bring this to the table. So, but most of you, like I am, when you talk to your CEOs or you talk to your COOs or you talk to your VPs of quality or whoever we're reporting to, we can't stop right there. We have to think about things in terms of the business and the services that we're providing. So in this space, there is a business case for looking at equity and for looking at the care that you're delivering from an equity perspective. It absolutely increases employee satisfaction. The data is very clear. There are all sorts of papers written on. If you focus on creating an environment of inclusion, your employees are going to be happier. And we're in the space of quality, right? We understand that happy employees make happy patients, right? Happy patients and happy employees, you get better outcomes. That correlation is clearly there. So anything that you can do in your organization that's going to make people happier and it's going to increase communication, people should not argue with that. It is the right thing to do. It also allows you to compete because the more attractive you can make your organization, the less nursing shortages you're going to have. If your institutions are viewed as the place to work, everybody's happy here, you won't have a healthcare worker shortage because everybody's going to want to work at your organization. So it allows you to be more competitive. And I was really excited when I started looking at all of the papers that are written on people who spend a lot of time creating an organization that's all about inclusion, celebrating diversity. They are more innovative. In every element of the organization, you're going to make more money, your employees are going to be happier, you're going to have better outcomes. And that is not me saying that, that's not UAB saying that, that is a national trend that people are starting to study now. So I didn't want to spend like the whole time kind of convincing you about why I do this, because I think you're quality professionals. You spent the better part of 6 hours understanding outcomes. This last slide, though, if you wanted to take away and say, why should we be looking at our data from this perspective, this slide sort of gives you an overview. There are social benefits, there are health benefits, and then there's also a business strategy to do so. But, so that sounds all good, and if I was, sometimes when you go to conferences like that, you're thinking about, well, what about me? I'm not UAB. I don't want to be UAB. I'm not that thing, right? Or sometimes when I'm going to Johns Hopkins, or I'm looking at Mayo, or I'm looking at other organizations, or I'm like, well, this won't work for us. So what we're wanting to do is to simplify. You can make this be as complicated as you would like for it to be, or you can enter the space of looking at equity and looking at outcomes from a more simple approach. But the key is that there's no right way to do it and there's no wrong way to do it. The thing is to invest in doing something. And I really do believe that it's not that everyone has to go hire a lot of people. This is not a new initiative. You don't have to have a diversity department. I am an N of one. There's everything that we talk about what we're doing, I do through partnerships, a lot of partnerships with our quality department. Part of that it's easier for me because I've worked with quality for a long time. But if you're working in quality now, it won't take a whole lot of resources for you to enter into this space. And I've already hopefully shared enough with you that it's the right thing to do, but there's also a business model why it's important as well. But I wanted to just kind of walk through and talk a little bit about the data and how you can do some equity monitoring. Fairly simply, I'm going to pass it over to my colleague, Mary Coleman, and she's going to come up and walk you through some of our data.
Thank you, Deborah. So these are just some very simple reports that give our patient feedback broken out by their demographic group. So we started with the simple ones that Deb was mentioning with gender and age and race, and are moving from there to get broader. But HCAHPS data is something that everyone should have access to, and really the filters that are applied to this data everyone should have as well. So I just wanted to show you some simple things that we were able to just run, put it in Excel, and break it out to see how do patients feel by the different groups. Or do we have glaring gaps that we need to pay attention to, and what can we do with this information? So just looking at gender first, all we did was just look at the domain level, keeping it simple with those 9 HCAHPS domains, keeping in mind the N size for each group and just the percent of total N to give a little perspective, and then the difference between the groups. So we stuck with top box, just the percent of patients who marked always. We felt that was a little bit simpler than moving on to to percentile rankings. It kept the data a little more straightforward. So you can just see, you know, where females rated lower and where males rated higher. And again, that's just two groups versus one another. But really the top box difference here, these differences have been fairly consistent over time. And then they also are not as big of gaps as some of the data we're going to look at later. So the big action that we took after this was our group decided that we needed to also capture current gender identity and current sexual orientation. So those questions have now been added to our HCAP survey so we can break the data out even more. The next thing we looked at was by age. So here's where we saw the biggest disparity was in the elderly population. So you can just look, again, I just did some simple conditional formatting in Excel to kind of bring out the areas that are lower and higher. And you can see that on most domains, the 80-plus population had a lower top box or a lower percent of patients saying always or saying yes, definitely to the questions. Well, that's a lot to take and try to tackle. So we narrowed it down to getting the information to the units that had the largest percent of the 80-plus population. And then if you're looking at the domains, care transition, the second from the bottom, we only have 47.6% of patients giving us the top box there. So even though UAB does very well on our percentile rankings for care transitions, with this group, over half of them are saying they're not, yes, definitely prepared to go home. And so that's something that we teamed up with the case management group, provided them with the comments that patients were leaving on HCAPs in this group so they could get more to the bottom of it and engage families better, because that's the big thing that came out of the comments from what patients were telling us. And then the last of these starting point reports that we did was on race. And we really had to take a step back here and look at the end size. So not getting us caught up in the top box differences, but we had to go back and say, look, the end sizes for some of these groups really probably aren't what they should be. We don't have the response rate that we should have. Some of these groups are not as well represented as they should be given our total patient population. So we also looked at primary language spoken and realized that we really needed to have the survey in Spanish. So that was something free that our survey vendor has done for us. And I've looked into it, and most of the large survey vendors will offer your survey in Spanish. So just something to think about as an easy step if you feel that your survey is not reaching patients in the language that, that they speak at home. So that was the big action there. We've also looked at this for our ambulatory environment. Your hospital may have other surveys that you can look at the data this way as well. But again, super simple. I'm sure you have someone in your quality department who could crank this information out very quickly for you. We're still working on the Auburn, Alabama versus UAB demographic. We don't have that dashboard up and running yet, but some of these were a good place for our team to start. So I'll turn it back over to Deb.
So what we're wanting to reach out to you and to share with you is a pilot process that our NALCE chapter, which is a regional chapter, and is a partnership with our diversity program, we're willing to offer all of you. And it's really simple. It's that if you've seen something that you would like to take back to your organization, but you want to dig a little deeper, because every situation is a little different. You may not want to look at patient engagement information. You may want to look at outcomes information, which we did. But we thought that we would start here because everyone's looking at patient satisfaction. But whatever, we can tailor it to whatever data you want to look at. But we're going to be regulated to enter into this space. And for me, I would rather be proactive rather to be told how you have to look at the data. And I know we just went through our Joint Commission visit, and this was a part of our Joint Commission visit. You're going to be asked what type of equity monitoring that you're doing in your organizations, either from a regulatory perspective. Other payers will look at it also, because health disparities are real. And insurance companies and the federal payers, they understand that equity issues, it's costing them more money. Not that everything comes back to money, but right now it's volunteer, but most of you know when CMS voluntarily does something for a period of time, eventually we're going to be told we're going to have to do it. So I think that the types of things that we're talking about is simple enough that if we could get ahead of the game and figure out how to enter into this space without hiring a lot of people, without a lot of resources, but also meet the true intent, which is we want to make sure that we're not inadvertently looking over something just because we're not sending a survey out in Spanish. Just because we haven't thought about that a 40-year-old patient communicated in one way about discharge instructions and an 85-year-old patient is totally different. And it was just looking at the data. And it was data we always looked at and we knew about. It was just asking those simple questions and making a few little adjustments that we were living with opportunities that we didn't even know about. It didn't cost us any more money. We didn't have to do anything extra. It was just looking at the data from that perspective and coming up with a couple of things that we can do to improve the data that we have. So if you're interested, we're going to do this in conference calls. It'll be sort of tailored to you. We can make a selection about what types of data you want to look at, and then we can figure out what's a simple dashboard process that you can share with your quality teams, you can share at the unit level, and also meet these regulatory requirements for equity monitoring. So if you're interested, you can contact Margaret, and she will connect us, and we'll be excited to start this partnership. I'll stop right there. If you have any questions from anyone? Oh, sure.
What method, what mode of survey instrument do you use, telephone or paper?
Paper.
Paper.
And our vendor is Press Gaining. Any other questions?
Other questions?
Thank you.
Okay, thank you.
All right. Well, we can actually finish early. Just in time so that all of you can go back and work a half day. We will not do a roll call and call you at the office and ask that question later today. So you're kind of on your own. So as we wrap up, let me just remind you of a couple of things very quickly, and then I've got just a couple of comments. Obviously, there are pads to sign for nursing CEUs, should be going around the room, and they're also located at the 2 scanners, so you need to sign one of them in addition to swiping your card. So if you need the CEUs, please get it. I do want to just acknowledge Dr. Williamson sitting in the back, our leader of the Alabama Hospital Association. He has done a terrific job. Many of you knew him as the former Director of Public Health and Medicaid Commissioner and whatever other state roles, and we're delighted to have stole him from the state and put him working as an advocate on behalf of our hospitals. He's done a great job, and I appreciate your attendance today, Dr. Williamson. And if any of you ever have a need, the association is certainly here to serve you. That's why we exist. And one of the greatest attributes of the association is the work that we can do with and through each other. That's what we exist for. In closing, let me just add a couple of thoughts in terms of kind of what do you do when you leave here other than do whatever it is you've thought about doing, and I'm sure there are plenty of things. Clearly, one of the things that we want to say again, there is no better time organizationally to make sure that you've eliminated all the possible silos that exist, as you've heard today with the various efforts that we've talked about, whether it be the 5-star, whether it be antibiotic stewardship, whether it be opioid use. Irregardless, we have to be able to cross departmental lines and to cross organizational responsibilities to be effective. Secondly, I want to say there's no greater time than we've ever had than today that we need continued physician engagement, physician leadership in our organizations. We're all good at perhaps what we do, but we can be better and we can be more effective by aligning physician leadership and physician engagement in what we do. I've often said that hospitals are little more than a workshop for physicians to practice the skills and the expertise that they bring to the table. And it's our job to make sure that that workshop works well. And that means letting those who work in that shop have a voice in what is going on and having a voice in how we can make improvements. So if you are not doing that, you're cheating yourself of the opportunity to have success. And I want to thank the physicians who are here today as we continue to make these endeavors going forward. Please take the simplified checklist that we've given you. I would encourage you to assess your organization with that. What you do with it is your organization's determination. We're not trying to mandate that from the association anyway. We're simply trying to create a helpfulness with that information. I think it's very clear to me, the work we've done in the last several months here, we have a lot of work to do on the 5-star and some of the other CMS programs. I think we've worked hard, whether it's being the patient experience side and patient engagement, all of those endeavors. But there's a lot that's going on that's impacting what happens in the black box of the computation and the formulas. And if we don't know the specifications and if we don't know how to drive the magic words and put things in the right classifications, the likelihood is we will not get the benefit of all the hard work that you put forth. So all I'm sure you want is credit for the hard work you've done. No one wants to game the system, but we also don't want to be penalized by the system by not knowing what the rules are, as you've heard that description earlier. Again, your hospital is probably looking to you to step up and be the leader in that endeavor because others in your organization may be occupied and tied up with other matters. The fact that you're here today hearing this message says that you've been delegated and assigned and being held accountable for some important activities in your organization. All I can say is go back, lead, make a difference, inspire, get other people on your team. You can make a difference for the lives of those we are privileged to serve. So I encourage you to keep stepping forward and doing that. It's a privilege to be with you on our 2 occasions each year. We'll be having our next one, I guess, in April. We'll get the agenda and everything out to you. So look forward to seeing you. And for those of you who've been around a few years, don't wear out. We've got lots of work yet to do. So thank you. Y'all have safe travel home.